مساء الخير جميعا. أنا صميم القاضي، طبيب أطفال من كندا. يسعدني أن أتحدث اليوم لكم عن Nutritional Challenges for Children and Youth Utilizing UNRWA. أنا سعدت كثيرا لما دكتور طارق حدثني عن موضوع المحاضرة، بدءا لأني طبيب أطفال ولأني مارست العمل في العراق في ظروف الحرب والحصار، وأيضا تعرفت على هذه المشاكل أكثر لما عملت في الأردن في مخيمات اللاجئين. هذه كانت فرصة طيبة أيضا لي أن نتعرف على كوادر الأونروا وعن كثب شفت اطلعت على برامج عملهم، الأمر اللي أكن له احترام كبير للمهنية وللانضباط العالي والعمل الرسالي اللي تقدموه. عند انتقالي لكندا أيضا اطلعت على هذه الإشكالات من خلال عملي مع عدد كبير من المهاجرين العرب القادمين لكندا والمجتمعات الأقل حظاً من الناس المقيمين في كندا، بضمنهم مجتمع الأربوريجينال كوميونيتيز. أود أن أشكر دكتور رامي حبش ودكتور محمد عوض على المعلومات اللي وفروا لي إياها لإتمام هاي المحاضرة. في هذه المحاضرة راح أتطرق إلى 4 مشاكل تخص التغذية. ربما من الآن راح نبدي نتكلم بالإنجليزي. These are the challenges, nutritional challenges for the 21st centuries. Iron deficiency, anemia, and iron depletion, failure to thrive, and we try to recognize the constitutional short stature and constitutional low weight, failure to thrive from birth to 12 months, and childhood obesity. I'm going to use the family health team model. This health model has been adopted and implemented by UNRWA recently to provide a comprehensive care plan for the whole family members and for the same member at different ages and stages of their life. It will be very helpful for us to understand the pathology, pathogenesis, and implementing medication recommendation. The issue of iron deficiency anemia among the children in refugees camp is a growing issue since long time, and now it entered the phase of being a severe public health problems that need not a treatment or management at the level of the frontline physician, but need an intervention at the public health level. It affects among children around 40% of children, and among other vulnerable group of pregnant ladies, 50% of them have this problem. The current policies indicate the screening test for iron deficiency anemia for people at risk. The table to the right shows us that the incidence and the prevalence of iron deficiency anemia in different vulnerable age groups from the late 90s of the last centuries to the 2005 and 2006. And it seems that there has been some improvement in the aspect of managing this problem, but a percentage of 25 or more is appearing as a new challenge now among the children, which tell us that there are probably ways that we can address this problem differently, and we look at it differently, as the current approaches has not been very effective in addressing this problem. This gentleman, R. Fuller, who's a theorist, futurist, architect, and a person who implemented the concept of paradigm change. And he taught us that if there is a model to address certain problem that struggle to treat or manage this problem, it's better to create a new model to look at the problem and address it, better than trying to modify the old model. Let's try to apply this to the iron deficiency anemia management. Historically, we look at this stage of the iron deficiency, which is the very advanced stage of the disease process. If we use the analogy of cancer, it is the very advanced stage and it's equivalent to invasive cancer. If we look at the pathogenesis of iron deficiency anemia, it progresses from normal iron storage to depletion of iron storage with just low ferritin as a lab marker for this depletion, then a progressive depletion to a level that affects the red blood cells and then the appearance of the symptoms. And that's equivalent to hyperplasia and dysplasia and carcinoma in situ and invasive cancer. So addressing cancer at this stage is a little bit late, and addressing the iron deficiency anemia instead of the iron depletion, it could be an advanced and late stage to manage this problem effectively. And that's what we call the paradigm shift, according to R. Fuller. So I'm going to discuss two aspects with the new paradigm. The first one is the pathogenesis of the iron deficiency or iron depletion, and how the family health model help us understanding this problem. So a pregnant lady who's already deficit with iron is going to be pregnant, and that will increase the iron deficiency status and create more anemia. We start treating this anemia, and then this mother will give birth to a child and start lactating and losing more iron. Ultimately, the child, by the time of weaning, will not have enough iron. So we know that breastfeeding is protective to iron deficiency anemia, but not when the mother is already depleted. And that's according to a study in 2005 from Saudi Medical Journal. Ultimately, the child will be a weaned infant with iron deficiency anemia, and at the school age, he will have another growth spurt that consumes more of their iron, and he will be again either anemic or more depleted. And in addition to other factors, including nutritional factors, parasites, the depletion of iron will continue. Then the child will enter another phase of growth spurt, which is the pubertal growth phase. And if this child is female, is going to have the menstrual cycle, which depleted her iron further, only to move to later on to be pregnant women with iron deficiency anemia, and so on. We inherited the iron deficiency anemia from one generation to another. If you look at the parameters to diagnose the iron, when we have normal iron status, all the lab parameters are normal. When there is iron depletion, it's only the ferritin is low. And when there is iron deficiency, it's the ferritin plus the iron and iron binding capacity. And only later on, the CBC or the hemoglobin will show deficiency. So if we shift our paradigm of screening iron deficiency anemia to iron depletion, and instead of just doing hemoglobin, we'll do ferritin at all at-risk age group, including pregnant women, infant upon weaning, children upon entrance of school, and youth upon pubertal changes. Then that may help us to address this chronic public health problem. There isn't much to say about classical symptoms of iron deficiency anemia. All of you, I think, you are familiar with it. But I'd like to highlight here two important symptoms that sometimes overlooked. The first one is decreased appetite. This is a very prominent sign of iron depletion. And also the pica. So the typical history of pica, we see the kids who are eating mud. In my experience, I find that many kids in our communities, they indulge in pickles as kind of pica, or sometimes cigarette ash, So you can ask about these indirectly as indirect signs of iron depletion. So this approach is address the iron deficiency status. So any person that you think that they are high risk for iron, you can start the test by doing CBC, of course, with ferritin. And if the ferritin is less than 12, then that confirms the iron deficiency status. If 12 to 20, then it's possible iron deficiency. If that test is negative and the ferritin is normal, then you could look for other causes, particularly in our communities, alpha thalassemia carrier, or it could be high ferritin because of like false high ferritin because inflammatory conditions, or it could be other type of anemia. If it's positive, then you start the process of assessing the patient for possible causes and start the treatment and maintenance and follow up the patient closely. If there is no response, then you check back for other possible hereditary anemia. The important thing here is to make sure that the iron status is, or iron depletion status is resolved, and it's 50% of the upper normal for the age. Few words about the food. So there are food that typically in Arab culture interfere with iron absorption. Tea, coffee, and milk. It's preferably not to take the iron pills or the iron drops or syrup with these beverage because they impair the absorption. Generally, the Mediterranean food is very rich with iron, considering beans, lentil, hummus, chickpeas, spinach, bread, seeds, simsim, tahina. All these things are rich in iron. Of course, tomato and orange juice are rich in vitamin C that help the absorption of iron. So be aware about these dietary habits and how when to give the iron, preferably if the person take milk for breakfast or tea for breakfast, then we may give the iron in between. When think about a public health approach for this problem, we need to consider all of the previous recommendations. So for the age-bearing ladies, diagnosis of iron depletion and treatment of iron depletion, the start weaning process at age of 6 months, and we'll come to this. Postnatal visit will continue with monitoring the ferritin, the hemoglobin, and we treat accordingly. For the children at school age, it's good to do screening. Probably for the infants, good to do the screening at 9 months or 1 year. That's according to the American Academy of Pediatric recommendation. That will help really to know if the weaning start at 6 months properly with solid food also. And if the child or the infant is deficit with iron, then start the treatment for that. The treatment usually with 4 to 6 milligram of elemental iron for 1 month and 2 milligram per kg per day for 2 months as maintenance. Monitoring every 1 to 2 months with ferritin and CBC is important until confirmed that the ferritin status is 50% of the normal. At pubertal ages, also another screening should be done and treat if there is iron deficiency status or patient only need maintenance and monitoring, particularly for menstruating girls. The next topic is the failure to thrive. And when we look at the failure to thrive, all the algorithms and the tables are really drowning and confusing. So I'll try to look at the problem of failure to thrive in a different way. We have 3 situations: either the normal child that we have no problem with their growth, or the abnormal child, and this is very clear that they're crossing the percentile and they are below the 3rd percentile. So that's also, there is a real problem here. It's worth investigation and spending time and resources here. I think the most irritating and confusing one is the one in the, like, just running below the 3rd percentile or the 5th percentile. So we don't know, like, do I need to do all these extensive tests? Is this normal? It's abnormal? How much I need to do? This is another example for these confusing tables, so that are not really helpful. So I'll just share that with you, and I'm sure that you know all the content. We'll go again and try to go back to our Fulham and do a paradigm shift here to how to look at this problem in a different way. The first thing is that any of these parameters to check the failure to thrive, and here I'm talking about the weight particularly, have very low predictive value. So one of them is not enough to diagnose failure to thrive. Usually we need more than one. So the child is running below the 5th percentile, decelerating, crossing these two major percentiles. Their growth velocity is running below the 5th percentile, and that may be a failure to thrive. But if they have just one and the other 2 or 3 are normal, then that could be a normal or constitutional low weight. It's very important to look at the weight velocity and how much is the child is gaining weight every month, and we can check that. And if the child is running below the 5th percentile but they gain weight properly, then this is very unlikely to be actual failure to thrive. It's just constitutional low weight. These are very helpful field charts from the WHO about the velocity or weight velocity on monthly basis, and can be used in the office to assess that weight gain, if it's within normal or not. I'm going to start with this a case study of 10-month-old boy that has weight that born with the weight on the 50th percentile, then start crossing the 5th percentile, and then that start continuously and steadily running below the 5th percentile. If we look at the other parameters, the height is normal. The weight for height, it's fluctuating, but it's running well on the 5th percentile or below the 5th percentile. So what do we do with that? What's my approach to confirm if this is constitutional low weight? Check if the child is healthy otherwise, physical examination and development. If eat well-balanced diet, adequate nutrition. If the family history is positive for a skinny parent or parents, like you can check them in the office. And I do basic blood tests to check for malabsorption. So CBC, ferritin, albumin, vitamin D, and B12 give us a very helpful picture about the absorption of the different nutrient. Vitamin B12 give us an idea about the absorption in the terminal ileum, vitamin D, fat-soluble vitamin, albumin, the total protein balance and metabolism in the body, and the ferritin give us an idea about the iron storage. I'll do white blood cells differential ESR and CRP and LDH, looking for any inflammatory conditions or tumors. And I'll do screen for major organ failure, kidney and liver, ALT and creatinine, if these are normal. And I examine the child proximal muscles. If the proximal muscles are of good bulk and the subcutaneous fat is good, comparing to this Western child, it's the same child after rehabilitation, you have rehabilitation. So subcutaneous fat is an indicator for fat storage, proximal for protein. If the child has all these normals and it's just running below the 5th or 3rd percentile, then I'll keep monitoring them. If they are infant every month, and if they are still growing and their growth velocity is normal, weight velocity is normal, then that's it. It's constitutional low weight. For older kids, I'll check them like every 3 to 4 months. This is another case study for a girl that is running for weight well below the third percentile, and similarly for the height. But there's the height velocity, the weight velocity, both are normal. And the weight for height is running just on the fifth percentile. So we'll do that same approach. And if she's growing well and gaining weight and height well, then no need for further assessment. Short stature, it's also, there is a constitutional short stature, and we'll discuss the approach for that. It defines as length for age less than the fifth percentile, but this could be normal. We need to rule out physical illness, and we'll come to that. And we need to pay attention to the psychological impact of short stature. The way I handle this is by helping the child to look for their strength instead of comparing their height with other kids. And every child, they have their own strength. And that will be very helpful to address the psychological impact for short stature. There's also charts available for normal health height gain or growth velocity, we call it. Usually it's between 4 and 8 centimeter per year. I ask those kids to come every 6 months after confirming their diagnosis. I ask them to come every 6 months and check it. If it's 2 to 4 centimeter per 6 months, then they are normal. That's just the same one. So here's the approach for the constitutional short stature. If they're healthy otherwise, a normal physical examination, positive family history, so one of the or two parents are short, have normal bone age, so I do left wrist X-ray and ask the radiologist to read their bone age. And if the bone age within 6 to 12 months with their chronological age, then there is no problem. And I'll do thyroid and growth hormone screen, IGF-1. I find it very difficult to have the estimated height for the parents in the office, so I don't do this often. But with this assessment and follow-up growth velocity, if the child is growing or gaining height properly, like on these serial visits, and then by the age they reach 14 or 15, they start their growth spurt and they catch up with their height percentile. That's the actual failure to thrive. And if we look at this infant was born with the weight at the 15th percentile, and gradually over the 6 months start plateauing and just running gradually below the third percentile. But if we look at this in a different way, we look at this infant that was having the same amount of calorie every day. And that's maybe the reason for that failure to thrive. And the most common one, because of the way that feeding is handled. So the child in the first 2 months of life, they need 8 feeds per day. And then this feed should be less and less, and the amount more and more. But if the child continued to feed, breastfeeding or bottle feeding every 2 hours for the first 12 months of their life, they will get the same amount of calories. And of course, we expected the weight to be flattened. This diagram shows us the energy requirement for the child for the first year. And we see here that in the first 6 months, there is a need for exclusive breastfeeding. At 6 months, we start introducing the complementary food, and that's for 2 reasons. The first one, at this time, the baby will need more iron than the breastfeeding can provide, and that's why we provide them with solid food, particularly cereal that's rich in iron relatively to their needs. The other one, they need a condensed source of calories to fulfill their growth requirement, because they will have a growth spurt at around 6 months. And that's the time when we introduce the solid feed and we start stretching the interval of breastfeeding from 2 to 3 to 4 hours gradually. And we'll come to discuss that. Then we start after that, after establishing good amount of solid food, we start gradually weaning the breastfeeding and or the formula, and we advance the solid food to fulfill or meet the nutritional requirement. Just for the sake of the time, I may go fast through some of the slides here. I think the main two issues that interfere with proper weaning process is the extended breastfeeding. So many of the families, they feed their kids for a long time. The other thing is the sudden weaning instead of the process of weaning, gradual weaning, which put a lot of stress on the mother, the babies, and sometimes we need to use some unpleasant or irritating agent to do that. Ideally, the child should feed 8 times for the first 2 months. Then we double the volume of the feeds and increase the interval between the feed, so a total of 6 feeds by 6 months. By 1 year, the child should quadruple the volume and feeds every 4 hours. We need also to introduce the solid gradually in between these feeds to fulfill the requirement as we talk. The last one that we'll come to discuss today is the obesity. And the diagnosis of obesity is based on IBM measurement, and it can be categorized as overweight, obesity, and severe obesity. So overweight when the weight is more than 85%, obesity is more, it's 97%, and severe obesity more than 99%. The recent studies by Dr. Nada Abu Kushuk from UNRWA shows that there is an increasing or growing problem of obesity among the children in the refugees camp, in all across the refugees camp, but particularly in Lebanon. It's 8.8% of the cases screened in her studies. For the diagnosis of obesity, there are a few things I would like to highlight here. First, when we look at the WHO chart, especially when it comes to obesity and morbid obesity, it seems that these charts overdiagnose these problems compared to CDC charts. So this is a measurement for a 15-year-old girl who is having IBM of 25 in the WHO chart, which put her in the obesity phase, while here she will have like a stage of or severity of obesity much less than that. So just be mindful for when you use the WHO is very good screening tool, but when you want to confirm or identify those groups that are in risk and you want to start treat them, I would use the CDC chart instead. Obesity, it affects different aspects of the child body. Of particular importance is the psychological effect, metabolic syndrome that increase blood sugar, risk of diabetes, and of importance is the effect of the bone, and particularly the skipped femoral head epiphysis. That's because of the pressure on the growing femoral head. It may split and disconnect from the root vascular supply from the femur and cause an avascular necrosis of the head. This is very important thing to notice in kids with obesity, and they usually present with knee pain, which make the diagnosis further difficult. Those kids is considered a pediatric emergency orthopedic problem. Don't let this child go home walking. Either give them a crutches or wheelchair, ask them to go next day to the orthopedic surgeon to pin the femoral head. The way you diagnose this, you can use the classical IP view, and it shows that what's called Killen lines, or the S sign with a unique or special view called the frog leg position. the etiology or the direct etiology, the etiology of obesity is very complex, but the one that I'd like to emphasize is the sugar intake. This is the amount of sugar in a pop drink. This is in a chocolate milk. This is in other beverages compared to water. So these become more accessible to kids, the juice and the drinks, that and make this load of the sugar a major pathology in obesity. Snacks, including chips and other salty and high-fat snacks, and the sedentary lifestyle. Of importance, I think, in the setup that we talk about of the children from the refugees background is the food insecurities. And food insecurities can be defined as the status or the state of having reliable access to sufficient quantity of affordable, nutritious food. That's the food security. The food insecurity is the opposite of that. And that's goes in stages from worrying about the ability to obtain food to start compromising the quantity and the variety of the food. And that's the serious stage where the kids start snacking with pops, with chips, with chocolate to compensate for their nutritional need. And then the more severe level of insecurity when the family cannot afford the meals, and then the family go and experience hunger. And this is not a problem of developing countries only, but it's also in the developed countries. So 4.4 millions of the Canadian has this problem, and few millions in the US. The other parameters here show some unique socioeconomic pattern. So Black people have a high percentage in that, both in Canada and the US, and the Hispanic communities also. And it's also common among the vulnerable communities and the Aboriginal communities. So there is a socioeconomic factor here. There is a growing evidence in the literature that there is association between food insecurities and obesity. When we look at the studies that came from UNRWA about the refugees camp, look at, actually these are the data that I got from the refugees camp about the real food, like a falafel sandwich or a cup of milk, and compare their cost in shekel to chips or soft drink or chocolate. We find that in Lebanon, for example, a whole meal, assume a whole meal made of sandwich, of cup of milk, it will cost 13 shekel, while in Gaza and West Bank, the same amount of food costs 4 shekel. While a snack or chocolate bar, snack and chocolate bar costs 4 shekel in Lebanon and 4 shekel in Gaza. So that's equivalent. So if the child has a good meal and they can snack, but if the child cannot afford this meal, then they will snack more, and that will cause obesity. Obesity management is early to have a treatment now for obesity, but the first stage is including prevention plus, which is avoid the sugar drink, breakfast daily, family meals, and healthy snacking, physical activity, and decreased sedentary life, and better sleep. I think the public health intervention here is important, especially when we talk about UNRWA experience with implementing different programs in public health to help that. For example, they can monitor the breakfast or the lunch in school, not to offer it, but at least they can make sure that the kids, they bring breakfast or lunch and monitor it's not like chips or something. Education, particularly for teenagers and adolescents in high school about their healthy lifestyle, when they become more cautious about their life and their body image, is important. So they become more amenable to this kind of education. And education for future ladies, for young ladies in high school, in housekeeping classes about healthy eating and healthy cooking could be an initial community-based intervention. Stage 2, it's more structured intervention with help of dietitian. Stage 3, comprehensive multidisciplinary intervention, and stage 4, need tertiary care intervention. I think that the important thing, and that's the last slide, I hope, for obesity is to understand the size of the problem and the diagnostic difference between WHO and CDC growth charts and the unique precipitating factor, lifestyle, sleep, nutritional behavior, and food insecurities in refugees camp. I think these are rich topics for study and research to understand the demographics of this problem, and then the public health team can come with effective management strategies. These are my references and questions, and thank you very much for your time.